Hi, so for our project, it included me, Stephanie Finger, Meryl Campbell, and Brittany Joyner. And our research article is Access to Dental Visits and Correlates of Preventative Dental Care in Children with Autism Spectrum Disorder. So, a little intro into our article. Children with autism spectrum disorder typically are not getting the dental health care needs met on a level that is expected. This population is at a higher risk for heavy plaque, dental caries, and oral infections. This is due to behavioral and sensory challenges. It is critical and crucial to explore and find avenues that will help elevate the dental experience for the autism population and to make sure it is presented to them in a way that suits their individual needs. Each autism patient is unique in their own way, and this is not a one-size-fits-all scenario. This article does explain the differences in care within the autism population, the access to care, the type of care received, and the quality of care. This was also all compared to the child's intellectual functioning. So next I'm going to talk about PICO. What is PICO? PICO is a mnemonic that is used in evidence-based research to help assist in preparing clinical research and narrowing down specific literature searches. So what does PICO stand for? P stands for the patient or the problem. I stands for intervention. C stands for the control or the comparison. And O stands for the outcome or the results. So for our article, the P would be the children with autism spectrum disorder. That's the patients. And the problem would be the standard of care is not the same across the board for children with and without autism. For the intervention, so there were assessments done in this research between the children and the parents. They were divided into two different sections: the Autism Treatment Network baseline, which is the ATN, and then the Registry Callback Assessment, the RCBA. The children's testing included baseline demographics, baseline intellectual functioning, adaptive behavior. Parents reported autism spectrum disorder symptoms, as well as any child behavior problems, if there were any. And the parents were tested on their stress and strain levels, parent activation, which includes the parents' knowledge, skills, and motivation related to their child's disability. And lastly, the parents were required to document their child's dental care within the last year. So if they received any preventative care, any fluoride, x-rays, sealants, anything of that nature had to be reported. For C, this research article focused on the dental care received by the children in the Autism Treatment Network compared to the National Survey of Children's Health. Data for children without healthcare, special needs, and children with parent-reported autism spectrum disorder. Correlates of obtained preventative dental care were observed within the ATN sample. These comparisons were done using the Fisher's exact testing with the following age groups: 4 to 5, 6 to 11, and 12 to 17. The outcome of the study showed that the ATN group received the same, if not better, preventative care compared to the group that did not have any healthcare needs. However, disparities still exist because within the autism spectrum disorder group, due to intellectual functioning, it is crucial that every child gets specialized care because not every child is going to be the same.
So the research in dental care visits sought to compare dental care received by children in the Autism Speak Autism Treatment Network, or ATN, to children in the National Survey of Children's Health, or the NSCH. The criteria for participant inclusion in the ATN sample were families with children ages 4 to 17 years old who were enrolled in the ATN. The ATN program is a clinical network focusing on comprehensive care for children with ASD. The study specifically examines families who participated in a follow-up visit as part of the ATN Registry Callback Assessment, or RCBA. In total, 375 families provided complete data on dental care. Dental received dental care received by children in the Autism Speak Network treatment network was compared to the National Survey of Children's Health for children without special health care needs and children with parent-reported ASD. This correlates to the obtained preventative services which were examined within the ATN sample. Participants included 375 families of children with children ages 4 to 17 enrolled in ATN. The families reported levels of preventative dental care that were similar to or exceeded the NSCH reported care, and this is from the article. The study found that children enrolled in the ATN received similar or better preventative dental care than children without special health care needs, but disparities still existed within the ASD population. The most significant correlation of reduced access to dental care was lower intellectual function. This finding highlights the importance of considering individual child characteristics when assessing dental care for children with ASD. This also comes from the article. Dental care represents one of the most common unmet health care needs for children with ASD, a population vulnerable to excessive plaque, caries, and oral infection. Demographic and systematic barriers to dental care have been identified for children with ASD, including financial cost, the lack of medical insurance, and the absence of a medical home, meaning they don't have an office that they go to. Child symptoms such as parent-reported challenging behaviors, communication difficulties, and sensory sensitivities, as well as the presence of comorbid intellectual disabilities, or ID, have been linked to difficulties obtaining dental care in this population. So what was excluded from the research, and was it justified? The studies excluded families who did not complete the second follow-up visit or who did not provide complete data. Additionally, children who were older than 17 years old and families who were unable to complete the dental care survey were excluded. This justification for this exclusion seemed to be aimed at focusing only on children with a specific age range, which was 14 to 17 years old, and ensuring data quality by only including complete responses. This exclusion is justified as it ensures the validity of the data, but could potentially induce bias by excluding a portion of the population who might have unique characteristics or needs. So how many studies were used and how does it impact the overall validity? It compared the dental care data from 375 families within the national data from 2016 to 2017. While the authors are not using a broad range of studies, these two key data sets, the ATN and the NSCH, are robust and well suited to this analysis. This limited number of data sets might impact the study's ability to generalize all children with ASD, but the data from these national and clinical sources provide strong evidence regarding dental care access for children with these disabilities. So research design, what's the difference between qualitative, quantitative, and mixed methods designs? And what type of research was used in the publication? So the difference is qualitative research typically focuses on understanding phenomenon through non-numerical data like interviews, observations, and case studies. It emphasizes the meanings, experiences, and interpretations of the individuals. Quantitative research uses numerical data and statistical analysis to examine relationships, trends, and outcomes. It seeks to quantify the problem and establish patterns. Mixed method research combines both qualitative and quantitative methods, allowing for a more comprehensive analysis of the research problem. So the research design used in the publication, I believe, was quantitative research design, as it focuses on statistical analysis of dental care access and preventative services for children with ASD. The comparison of data from the ATN sample with NSCH data was done numerically to explore differences in preventative dental care services received and to identify correlates correlates of access to care. Quantitative methods were used to measure these variables and identify patterns. Thank you for your time. And this was Marilyn Campbell speaking. Thank you.
Level of evidence. What level of evidence is your publication? This study utilizes level 6 of evidence, cross-sectional studies without concurrent controls. Why this level? A cross-sectional study measures the outcome and the exposure at the same time to determine the association between the two. When measuring the outcomes and exposures at the same time, a correlation or non-correlation between the outcome and exposures can be recognized. The children were compared in two groups from ages 4 to 17. The comparison was between a group of children with autism and a group of children without autism under the provider. So what does this do for validity of the study? The cross-sectional study increased validity by highlighting the challenges and barriers faced by children with autism spectrum disorder, or ASD for short, in accessing dental care by comparing the amount of dental visits, number of preventative dental services, and success at the last dental visit. The article also explores various factors that are correlated with the likelihood of children with ASD receiving preventative care. These factors include socioeconomic status, parental education, and availability of specialized services. Is the publication credible? The study is credible due to the collaboration of the Autism Treatment Network and the National Survey of Children's Health, as well as the statistical analysis of the quantitative research approach. The data was analyzed numerically in order to identify patterns and identify obstacles for access to dental care for children with autism. So what would we change about the way we practice dental hygiene based on what we've read? Why or why not? We believe this study can benefit the way we practice dental hygiene due to identifying the challenges for patients with autism. We can distribute resources and guide families with lower socioeconomical status to resources that can overcome these obstacles that they must overcome to receive standard of care.